Back in January of 2020, we did an episode on waste in U.S. healthcare. It was somewhat discouraging, but we do have data on different ways we might address it, and that's the topic of this week's Healthcare Triage. Special thanks to Austin Frack, from whose Upshot column this episode was adapted. Research has established that as much as a quarter of American health spending is waste. There are two basic ways of tackling it: by focusing narrowly on specific types of patients or on the system as a whole. The patient-centered approach starts with this fact: a relatively small group of patients, 5%, account for half of all health spending. It's widely believed that making so-called super utilizers even a little healthier, for example, giving them extra help once they're out of the hospital to prevent a quick return there, would yield substantial savings. This idea, based on some weak evidence, has received considerable media attention and government support. A study published in 2020 makes clear it's not so easy. In fact, the study's results are likely to be viewed by many as a major disappointment. Yet they also help guide us to what may be better strategies for cutting waste. To the research! The study, published in the New England Journal of Medicine, was a big test of the people-focused approach, a randomized controlled trial of a program in Camden, New Jersey to reduce super-utilizer spending. About 800 very sick patients were randomly assigned into the program or to usual care. To try to avoid a repeat hospitalization, the program provided an unusually large amount of care to very sick patients after they left the hospital, including from registered nurses, social workers, licensed practical nurses, community health workers, and health coaches. In the 3 months after a hospital stay, an average patient in the program received 7.6 home visits and 8.8 phone calls from staff. In addition, program staff went along on patients' visits to physicians, which averaged 2.5 per person. The result of all this effort? For the 6 months after randomization, patients in the treatment and control group had about the same chance of returning to the hospital, the same number of return hospital visits, the same amount of time spent in the hospital overall, and the same hospital costs. It's possible these measures differed across groups in small ways the study wasn't large enough to detect. But even if there are no differences, this doesn't mean it's impossible to reduce readmissions or healthcare spending of targeted patients. Some previous randomized evaluations of other programs have found reductions in hospital readmissions of 15 to 45%, and in some cases, reduced spending. It's also important to understand that the Camden study was conducted in patients who had more varied and complex needs, and thus higher healthcare spending compared to those in existing models that have shown success in reducing costs. The other approach to fighting wasteful medical spending starts with looking at healthcare as a system of goods and services, medications and surgical procedures, administrative processes, and physical infrastructure. Some of these enhance health and others don't, while some of it costs more than its benefits warrant. If you can identify wasteful goods and services and deliver effective care at lower prices, you can make the system more efficient for everyone. This idea is behind many policies that change how Medicare pays for care. One advantage of the systemic approach is that it's easier to replicate than programs focused on superutilizers. If eliminating or replacing a drug, procedure, or administrative process means that spending at a hospital goes down, it's relatively simple to adopt that change at other hospitals. But conceptually simple doesn't mean easy in practice. One barrier lies in the fact that the revenue of major healthcare providers is reduced when strategies to reduce waste are successful. This may be why big health systems are resistant to systemic change and prefer patient-focused approaches. But a commentary in the New England Journal of Medicine argues in favor of a system's view of cost-cutting, pointing out that a focus only on the relatively few high spenders could miss a lot of waste. Even though the rest of the population may use less healthcare than superutilizers, collectively, they could account for as much or more waste. Another concern is that when cuts are made to health spending, patients could receive lower quality care and might have worse experiences. Cutting waste without harming quality is hard, but not impossible. Some Medicare programs and private insurer initiatives in recent years have succeeded in doing so, if only a little. The people-focused approach, on the other hand, is more likely to improve some patients' experience because it involves additional preventive care. This could manifest itself as less pain or anxiety and more satisfaction with care. But saving money this way requires accurate predictions of who is more likely to use a disproportionately large amount of healthcare. We don't yet know how to reliably do this for enough people to make the approach efficient. A commentary on the Health Affairs blog points out that high-cost patients are not all alike. They require different mixes of services to avoid costly outcomes. That calls for a lot of fine-tuning, which itself costs money and poses coordination challenges. It's also harder to replicate. The Camden study, unfortunately, did not measure patient experience, which might have improved if patients did better in some ways, and at no statistically significant additional cost, that could make its efforts worthwhile, even cost-effective. That's what an exclusive focus on reducing spending misses. The answer isn't necessarily to pick a patient or system-focused approach to reforming healthcare, but to do both effectively. Hey, did you enjoy this episode? You might enjoy this previous episode on child obesity research. We'd like it if you'd like the video and subscribe to the channel down below, and head on over to patreon.com/healthcaretriage, where you can help make the show bigger and better, even during a global pandemic. We'd like to especially thank our research associates, James Glasgow and Joe Sevitz, and of course, our Surgeon Admiral Sam.